Yes.
I'm going to ask you some questions now about testing for infections. I understand from your statement that all the patients at Cardiff have been tested both for HIV and HCV, hepatitis C, and told of their infections by the time you arrived at the clinic in 1996.
Yes, that's correct.
Was there anything that you heard from patients or from the staff that had been at the centre under Professor Bloom about the way that was managed by Professor Bloom?
I've heard the statements of the patients, and I've obviously heard the oral evidence of the patients, and much of the oral evidence I knew before I saw that because they explained that to me. The only person who was working at the Haemophilia Centre at the time that the information about HIV would have been related to the patients was Jenny Jones. Dr. Dasani wasn't working there at that time. I think he started in 1989. The other person who would have been there would have been Dr. Elizabeth Moffat, who was the research registrar around that time. It's difficult for me to really give any further answer. The person who might well have directly observed this is Sister Jenny Jones.
And do you recall any conversations with her about that time and the events that unfolded at that time and how they were managed?
I don't specifically remember her describing. I mean, she did describe some specific cases to me, but we clearly can't discuss specific events. But in terms of general terms, she didn't say to me anything specifically about how people were informed of their HIV infection. Of course, the person who informed most people about their hepatitis C infection was Dr. Dasani, because he was working at the Haemophilia Centre at that time, and also Dr. Simon Davis, who was the locum consultant around 1991. He took 1992. He took over as locum consultant when Arthur Bloom died. So he would have been, both him and Dr. Dasani would have been there when people were told of their hepatitis C result.
So most of your knowledge about how testing for infections and delivering results to people and so on was managed comes from the patients directly either to you or through the information they've given and that you've become aware of to the inquiry?
Yes, that's correct, yes.
I also understand from your statement that the partners of those hepatitis C infected patients had also been tested prior to your arrival at the centre in 1996, and they'd been tested by Dr. Dasani, and they were all negative. Is that right?
That is correct. Dr. Dasani undertook a sort of a comprehensive process of offering testing to partners, and it is correct, they were all negative for hepatitis C.
And so the testing that has taken place since your arrival in 1996 has been of partners of those infected with HIV. Is that right?
Yes, we offer HIV tests for partners of people who are infected with HIV, and that's been going on ever since I've been there and continues to today.
And you say in your statement that was led by Dr. Dasani. Have you been involved in that process yourself?
Yes, I've been involved in that process, but Dr. Dasani, I think it's important to recognise that Dr. Dasani was an expert in the management of HIV, and he took the lead in these sorts of processes related to HIV. But certainly, I would have been involved in offering tests to partners on a fairly regular basis.
And you also say that patients who were treated with pooled plasma products and who were HIV or HCV negative were also tested regularly for those viruses.
Yes, so when I arrived, there was already a surveillance program in place where people were tested every 6 months if they were on plasma-derived products, and that continued until we introduced recombinant, after which we stopped doing that once recombinant products had been introduced.
So for those very few patients who remain on plasma products, do they still get testing?
No.
And you also say that you tested new patients coming in from other centres and from abroad for HIV and hepatitis C.
Yes, we inherited quite a few people who were infected with HIV or hepatitis. Often they were coming to Cardiff to attend the university, and we would take over their care whilst they were at university. They all already knew of their HIV and hepatitis C status, but we retested them when they arrived with their full knowledge and agreement.
What is the process when you need to test somebody for HIV or hepatitis C? What's the conversation that you have with them in order to get their consent?
This hasn't happened for many years. I don't remember doing this for a very long time, but the discussion is around what the test is, particularly about the implications of the test, and with HIV, why it's possible that the individual may be at risk of having contracted HIV. This often is for people who've moved in from abroad and who may have been treated with blood products in the past, and so we don't have a record of the blood products. The patient group in Cardiff is really quite stable. Relatively few people leave South Wales, relatively few people come, so it's a very unusual event, but we also will discuss implications for insurance and mortgages and life insurance. So we have those sorts of discussions, but it must be 20 years since I had this sort of discussion with anybody. There was one case, I remember, one individual where we made a diagnosis of hepatitis C of a lady with von Willebrand's disease who had not been to the centre for a long time, and that was made after I started working in the centre. Again, we discussed with her the reason for wanting to do that. It was because we thought she might possibly have received a pooled blood product in the past, and it unfortunately proved that was the case.
And when you arrived at the centre, you had a policy to keep patients on the same batch of product where possible to reduce donor exposure. Presumably that's fallen by the wayside, has it, with recombinant products?
To a degree, we still tend to try and stick to similar batch numbers, although there isn't really any compelling reason to do that. I think it's out of habit that we just continue to do that.
And you also describe in your statement how vaccinations were offered against hepatitis A and hepatitis B. Can you just explain why those vaccinations were offered in 1996 when the plasma products patients were receiving, were virally inactivated?
I think it was mainly because there was a small risk from blood transfusion still from red cells, and that people with bleeding disorders are more likely than other people to need a red blood cell transfusion, and so that was the reason. Of course, when I arrived, people were on plasma-derived products, and although there had been safety for 10 years, there was always this underlying concern that perhaps there would be a kind of a breakdown in the manufacturing process that led to another problem, which was one of the main arguments that from my point of view for recombinant.
And do you still offer those vaccines to patients?
No, we don't routinely at the moment, no. Children, I think, get routinely vaccinated for hepatitis B anyway now, but we don't routinely offer hepatitis A vaccination, no.
And why is it that those with bleeding disorders are more likely to need red blood cell transfusion?
Well, at that time, because a lot of people were not on prophylaxis, so if they started to, for example, have a bleed from a stomach ulcer, they might bleed a lot more than other people. Whilst people with bleeding disorders are more prone to that, because the vast majority of people with severe haemophilia are now on prophylaxis, to some degree that's mitigated against.
So I'm going to ask you now about the current treatment, the current the clinics that you hold for your patients and the reviews that you undertake. So how frequently would you see somebody with severe haemophilia in a clinic?
Well, if someone's stable, it would be every 6 months. Younger children, it might well be every 3 or 4 months, particularly when they're very young and are initiating treatment. We also have a policy of open access, so essentially if someone wants to discuss something or has an intermittent bleed, they can come to the centre at any time and be seen, or if it's not that urgent, they can ring in and be slotted into the next clinic. So anyone can essentially come when they want to if they have a problem.
And what about a patient with moderate haemophilia?
So again, every 6 months we would offer people with moderate haemophilia an appointment every 6 months. People with mild haemophilia, it might be once a year, would be the average. But if a person has hepatitis C or HIV, they would be seen more often, at least every 6 months, if they had active hepatitis C.
And a patient with von Willebrand's, how often would they be seen?
Well, type 3 severe von Willebrand's at least every 6 months. There are some people with type 2 von Willebrand's who have really quite a significant bleeding pattern. They would be seen at least every 6 months in a formal clinic. But people with type 1 von Willebrand's, where it's a more mild disease, maybe once a year or often once every 2 years. Some people have, they can go 10 or 15 years with no problems, and then they might have an issue, for example, related to when they need a surgical procedure.
And you described in your statement that at every appointment, blood samples would be taken to get a blood count for a patient infected with HIV, a CD4 count, a liver function test, viral loads for an HIV-infected patient, and later on HIV virus resistance tests. As you've described, there was a period where regular testing for hepatitis C and HIV were undertaken if the patient was negative for those viruses.
Correct.
And for testing for hepatitis C genotype and PCR testing when that became available. In a clinic where you see a patient today, what tests are you doing on a regular basis?
Well, in a clinic today, we are mainly doing tests to look for anemia and iron deficiency. which would be a full blood count and a ferritin. We would be testing for factor VIII inhibitors on a regular basis, and we would do liver function and renal function tests. People with HIV have their tests ordered or requested by the bloodborne virus clinic, and then they come to the Haemophilia Centre with those forms for the test to actually be done. So we are no longer involved in requesting the test for monitoring for HIV. For hepatitis C, people will be monitored routinely through the Haemophilia Centre, and what we now have is the joint clinic with Dr. Shrivastava, who's the consultant hepatologist. He will advise us on what blood tests to perform, and so we follow the advice dependent on what he's suggesting.
And can you describe for us the consent process that you would undertake with a patient at a 6-monthly regular clinic appointment for those tests?
For a routine clinic appointment, we would just say to the patient that we're going to do your routine tests. We, test for anemia, look for an inhibitor, which is what people are aware. We certainly don't take more formalised consent than that.
So, if you were testing for a particular virus, a paravirus or something of that nature, would you have more formal consent process?
We certainly would now, yes.
And what would be the nature of that conversation? Can you describe that typical conversation you might have if you were testing for paravirus, for example?
Well, that hasn't come up for a very, very long time, although it did come up this week. I wasn't the clinician involved in that discussion, and it's a discussion about an individual case, so we probably best not, but we would have no reason to test for parvovirus, so I don't think that would come up unless the individual patient requested it at the moment.
So are there circumstances in which you have, at a regular clinic, have to go into a more in-depth discussion with patients in order to obtain consent for particular tests, or particular blood tests?
Well, genetic tests, we have a more in-depth process, and we have a system of written signed consent for taking genetic tests, those to look for the mutation that is causing haemophilia A or B. But now it's much more possible to test for all sorts of genetic disorders because of the huge progress that has been made in genetic testing over the years. So we are now offering genetic tests for families with von Willebrand's disease or with factor XI deficiency or with platelet disorders. And so we would go through a much more formal consent process, and we have a written patient information sheet and a consent form, and they would sign written consent for that process.
And I understand from your statement that the centre no longer stores samples. Is that correct?
That's correct. Since we transferred to recombinant, there didn't seem any reason to continue to do that. So we stopped storing samples when people converted to recombinant.
And what's happened to the stored samples?
I can't answer that for definite. What I can say is that the stored samples are no longer present. No one can tell me exactly when they were destroyed. It is possible that they were destroyed after there was a failure of one of the virology freezers, but people can't tell me definitively. What they can tell me definitively is that they no longer hold any samples.
When you were storing samples, what were patients told about that? When routine blood tests were taken, were they told that their samples were being stored back in 96, 97?
Yes, they were told that we were storing samples in case there was a problem with another infectious agent, and that we might need to test those samples in the future. So that was the discussion that was had regarding those samples.
And so was that discussion a process by which you were obtaining consent from the patient to test for future viruses, or was it a discussion on the basis that you would then come back to get their consent to test for those viruses if that became appropriate?
It was on the basis of that if, for example, a test for variant CJD became available, we would go back to the individual and discuss whether they wanted that test to be done or not.
Can I take you to a document to see how this might have worked in practice? It's WITN 402 9008. 9008. So we can see here this is an article, long-term follow-up of patients treated with intermediate factor VIII concentrate BPL8Y, and your name, along with Dr. Dasani and Dr. Brown, as authors. And if we look into the summary, second sentence, long-term surveillance, first sentence, studies of clotting factor concentrates are important to detect infrequent or delayed complications and to provide data against which newer products can be compared. And we've assessed the long-term use of BPL8Y factor VIII concentrate. So that's the purpose of the study. And we can see that you collected data from 33 patients treated over 96 months. And you tell us in your witness statement that as this was a surveillance study, this is not something that you sought ethical approval for or consent from the patients. Is that right?
Yes, that's correct. We thought that this was within the criteria of a service evaluation rather than a clinical study.
And if we turn over the page, Shamak, there's a patients and methods. We can see there the method that was used. 33 patients being treated exclusively with BPL8Y. The patient's notes were reviewed and data collected. And then at the top of the next column, virological testing had been carried out on a 6-month basis. So that presumably is a reference to the testing that had been undertaken at the clinic reviews.
That's correct,
Yep.
Yes.
And then moving down to the end of that paragraph, stored sera were used for parvovirus antibody testing by ELA-ISA. So it's really that I wanted to ask you about. In this study, were you testing the stored sera for parvovirus?
In some cases, those were tested on stored sera. In some cases, the individuals were invited up to the Haemophilia Centre to have samples taken for the parvovirus test.
So, while and if the sera was, if the testing was done on stored sera, are we to understand then that the patients wouldn't have consented to that test?
Yes, that's correct.
So, some of the patients in this study would have consented to parvovirus testing, but wouldn't have understood that it was to be reported in this article. Is that right?
I don't know. I wasn't directly involved in that conversation. That would have been Dr. Dasani and Dr. Brown directly involved in that conversation, so I don't know exactly what was said.
And should the patients have been should the patients have consented to their stored sera being tested for parvovirus?
I think, in retrospect, looking at this now, I think that they should have been asked to have their stored sera tested for parvovirus. Yes.
Do you know whether the patients were told the results of the tests for the parvovirus?
I don't know the answer to that, I'm afraid.
Would that have fallen to Dr. Desani?
It possibly, or to Dr. Brown. I think the other point just to make about the results is that I think that, because I've obviously read this paper again now, this was written soon after I started in Cardiff, and reading it again now, I'm not sure that we have interpreted the results correctly with regard to those parvovirus results. The reason I say that is that these people, by definition, were receiving 8Y. 8Y has immunoglobulin in it, and it is possible that the parvovirus antibody that we were picking up in that test was in fact coming from the concentrate rather than a demonstration that the individual had parvovirus in the past. So I think it's difficult to interpret the result of that, and that's something I've become aware of when I've reread this paper and looked at it again with fresh eyes. I think, however, there is no doubt that we should not have tested those stored sera without talking directly to the individuals involved.
And equally, should the patients have been told what the outcome of those tests were?
I think they should have been told the outcome of those tests, but as I say, it is possible we would have given them the wrong information or potentially misleading information. I think the conclusion that I reach now is that we shouldn't have tested them at all because we could not derive a clear understanding. The reason this was of such significance at that time was that there had been a case report from the Royal Free Hospital of an individual who had contracted parvovirus, apparently from concentrate, and developed significant anemia. And parvovirus was being seen as an important sort of potential marker for pushing for the introduction of recombinant factor VIII around that time. However, I fully agree that I don't think those samples should have been tested.
And I'm anticipating from your previous answer that you won't know the answer to this, but were those patients followed up as a result of what was thought to be positive parvovirus tests?
Well, they were all being followed up regularly. Of course, that test is a test that, if it is positive, shows past parvovirus infection, not current parvovirus infection. And something like 50 to 60% of the UK population will be parvovirus IgG positive because they've had parvovirus in the past. And so it's not a disease that leads to chronic problems. You have parvovirus, you get over it. It's what sort of a classic childhood illness, a little bit like measles. You have it, you get over it, and then that is there's no further consequences of that. So all of these individuals would have been being followed up through the clinic, and any clinical symptoms would have been investigated appropriately. But I don't think parvovirus would have been an issue in that situation.
Sticking then with what you have treatment of patients at the centre. Again, similar question to the one I asked you earlier about testing for infections. Is there anything that you've heard from patients or from, in particular, Dr. Zizani or Sister Jones, about the way that the patient's treatment was managed by Professor Bloom during his directorship of the centre?
No, all I know about the treatment is on the two protocols that I've submitted from 1983 and 1985. That's all I really know about the treatment. I know from discussion with patients that there wasn't a full discussion about the different types of treatment. Or necessarily all the potential risks of treatment. That's all I know. I don't know anything further. Again, Jenny Jones would have been present at those discussions. Elizabeth Moffat would have been present at those discussions, and they may be able to give a better answer than I can.
And your knowledge of the protocols, the protocols and procedures that you've exhibited your witness statements, come simply from those documents, do they, rather than from anything you've gleaned about how they were implemented from discussions with patients or Dr. Tazani or Sister Jones?
That's correct. I was unaware of those documents until we received the request from the inquiry for documents, and I went through everything I could find, and those were documents that I was unaware of their existence until I looked through sort of the old kind of files that I'd inherited from Professor Bloom's office.
So you didn't have conversations from someone saying, well, this is the treatment protocol we used to apply. See this document.
No, I didn't know. But Jenny Jones would have followed those protocols. She would have worked directly off those protocols.
Moving on then to how HIV is managed and has been during your tenure at the centre. You've already told us that Dr. Tazani was an HIV expert. The inquiry's heard evidence from Dr. Winter, who described himself, I think, as an HIV physician. Is that the same situation that Dr. Tazani was in?
Yes, Dr. Tazani had, because HIV was a very new disease, and he had been looking after people with HIV since it was first recognised, he was probably as knowledgeable about the management of HIV as anybody at the time. He attended British HIV Association meetings, he kept up to date with the literature, and I think he could be considered as a HIV physician in the same way that Dr. Winter could be.
And you've also said that you were able to refer some of your patients to the infectious diseases team led by Professor, and I'm not going to be able to pronounce his name correctly,
Borisevich.
How frequently did you refer such patients?
Well, this was before I'd arrived. Dr. Tazani told me that he would sometimes seek Professor Borisevich's opinion on patients. It was certainly not a formal thing. That was all before I arrived. One of the very first things I did after arriving in Cardiff was to approach a consultant in infectious diseases called Dr. Friedman, and he was again an expert in HIV. And we then started working jointly with Dr. Friedman, both myself and Dr. Tazani, to look after people with HIV. And Dr. Friedman started to come to the Haemophilia Centre and do joint clinics with us so that he could advise the people directly. And so he and Dr. Tazani then, all treatment-related decisions in terms of what anti-HIV medication, the decisions were taken jointly by Dr. Friedman and Dr. Tazani after that time.
And then at some point the HIV care moved to the blood-borne virus clinic. Was that a new service that was set up?
No, Dr. Friedman ran a bloodborne virus clinic and had done that all the time I'd been in Cardiff. The people with HIV who were being looked after in the Haemophilia Centre expressed a very strong opinion that they wanted to stay under the care of Dr. Dasani, and so they continued to be looked after by him with Dr. Friedman doing joint clinics. And so it was really only after Dr. Dasani retired that the expertise within the Haemophilia Centre needed to be more formally supported by the bloodborne virus clinic, and it was after that time that we started to people started to go to the bloodborne virus clinic specifically so that they could see specialists, because of course we weren't in the way that Dr. Dasani was. We weren't specialists in HIV management.
So is this right that currently all patients with HIV are managed? Their HIV is managed by the bloodborne virus clinic, and the bloodborne virus clinic runs clinics on the same day as the Haemophilia Centre. So while there aren't joint clinics, the patients only need to attend the hospital on one day.
That's correct. We tried very hard to make that the case, so that the individual would go to the bloodborne virus clinic first. They would be given their blood tests. They'd come to the Haemophilia Centre. We would review any issues related to haemophilia and add any blood tests like inhibitors or whatever, and then the haemophilia nurses will take the bloods. So that's the process.
And presumably, is there a mechanism by which you can discuss patients with your colleagues from the bloodborne virus clinic? So there's joined up multidisciplinary care.
I mean, at any time, I can contact a member of the bloodborne virus team and discuss an individual that I might have some concern about. They're very, very accessible and very easy to contact.
And then moving on to arrangements for managing patients with hepatitis. In your statement, you say that prior to your arrival, patients were being managed by Dr. Tisani, with referrals being made to England for second opinions, and some liver transplants having been undertaken in London and Cambridge. Is that right?
That is correct, yes.
Are we to understand from that there was no hepatology expertise within Wales at that stage?
There was certainly no hepatologist in Cardiff. I don't know within Wales. It may be that there were none in Wales. There was certainly no liver specialist that could, for example, undertake liver transplantation in Wales, and there still aren't. That's a service that is not available in Wales, liver transplantation. But in Cardiff, there was no, when I started in 1996, there was no hepatologist in Cardiff. And if we wanted to have an opinion locally, we would have to talk to a gastroenterologist who certainly had more knowledge than we did about chronic liver disease, but they weren't a hepatology specialist.
And you've already described to us that when you started a regular outpatient clinic for those with hepatitis. Were you running those clinics with advice from Dr. Friedman? Is that how it worked?
So Dr. Friedman was a specialist in treatment to eradicate hepatitis C because he was an infectious disease doctor. Dr. Friedman wasn't a specialist in the management of chronic liver disease. So when it came to eradication of hepatitis C, Dr. Dasani, Dr. Friedman would jointly come to decisions on what treatment should be offered. If we were concerned about an individual having progression of liver disease, we would have to seek the opinion of a gastroenterologist, or Dr. Dasani would sometimes contact one of his contacts elsewhere in the UK and directly refer the individual. So, for example, if there was concern about an individual having progressed liver disease, he might refer to London or to Cambridge to say, should this individual be assessed for a liver transplant? And the answer would come back yes or no, and we would refer like that. About 1 or 2 years, sorry.
Yes.
About 1 or 2 years after I started in Cardiff, one of the gastroenterologists did a secondment to the liver unit in Birmingham, and I think spent about a year there as sort of part of sort of more specialist training. That was Dr. Thomas, and when he came back to Cardiff, we started to use him as our hepatology consult, and because of his links with Birmingham, people then were started to be referred for Birmingham if they had problems with liver disease that were progressing.
So is this right? Up until I think 2003, you were managing your patients who were infected with hepatitis C. You were managing their care with assistance from at various times Dr. Friedman or Dr. Thomas once he came back in, I think you said in your statement, 1998.
Yes, that is all correct. We didn't have access to formal hepatology, and just to make the point that this wasn't just people with inherited bleeding disorders, this was everyone in the Cardiff area. There was no access to hepatology service for anybody, so it wasn't a specific issue for bleeding disorders, but of course, because so many people with bleeding disorders had hepatitis, it was disproportionately affecting their care.
And then you described in your statement how between 2003 and 2009, you were able to establish a joint clinic with Professor Godkin, who is a hepatologist,
Yes.
and able to able to review patients with more progressive liver disease that way, and then make referrals to Birmingham in some cases.
That's correct. So Professor Godkin came to the Haemophilia Centre and did joint clinics with either myself or Dr. Dasani, and people with liver disease would be seen in that clinic. He would see them, examine them, advise them, and if necessary, he would make the referral to the centre in Birmingham.
And you've also described how that wasn't part of Professor Godkin's brief, as it were. He had to fit that in on top of his existing commitments, and so it wasn't something that could lasted beyond 2009.
That's correct. It wasn't in his job description, and I obviously don't know the exact ins and outs of it, but he has explained to me that he was told that he couldn't continue to provide that service because it wasn't, part of his job plan. But I don't know the exact how those exact discussions went ahead. Even though he stopped coming to the joint clinics, he still was available. So if, for example, I was concerned about someone or one of my colleagues was concerned, we could still go and knock on his door or contact him by email and say, this is the situation, and then he would see the individual very quickly in one of his clinics. So he was still available. It was just that he wasn't available to come and do that joint clinic.
So the reviewing and monitoring was left to you on a day-to-day basis, with escalation to Professor Godkin when you thought that was appropriate.
Yes, so we had to undertake the surveillance for liver disease, which I think was clearly something that I don't think was optimal care, because we're not trained in what we were being asked to do. And whilst when Dr. Godkin was coming to the joint clinic, he was obviously appropriately assessing people, we were, I think, not providing optimal care during that period because that wasn't a possibility.
And you've explained in your statement and exhibited various documents that show that that this gap in service was identified and a specific recommendation was made to ensure appropriate consultant and specialist hepatology input into the treatment of patients in 2011, and you were involved with that process. And
yeah, so that was the...
Yes, sorry, no, yes.
So that was a ministerial review of inherited bleeding disorders in Wales, and a number of findings came out of it, but an absolute key finding was that the Haemophilia Centre in Cardiff needed access to a consultant hepatologist who could do the joint clinics and who could manage the patients optimally. By this stage, Swansea Haemophilia Centre did have a consultant hepatologist who was seeing patients there. And one or two of the people from Cardiff went to Swansea to be seen by that hepatologist so that they could access services that were appropriate to their needs.
And you were also involved in the Inherited Bleeding Disorder Action Plan, which seems to, as I read it, it seems to, that funding was confirmed in 2014-2015 for consultant hepatologists. Is that your understanding as well?
I wouldn't like to be sure to say what my understanding was. I wasn't involved in the discussions because there would have been discussions between the Welsh commissioners and the Cardiff and Vale board about the funding arrangements, which I wasn't involved in that process at all. So I don't know how those discussions panned out or what was said.
Do you know why it took from 2011 to 2016 for a hepatologist to be engaged?
Again, the information that will give the clearest answer would come from the hospital board, who would have been it would have been their role to make that appointment. My understanding was that the post had been advertised earlier, but a suitable candidate hadn't come forward. And the suggestion that has been said to me, but again, can't say this with complete authority, was that the job plan had included that individual would also have to undertake other general medical duties as well as being a hepatologist, and therefore it was thought unlikely that you would get someone who really wanted to do hepatology to come and take that post on. That's what I've sort of been led to believe, but I can't say that with real authority.
And you've said very candidly that was not optimal care. What impact do you think that has had on your patients? The fact that certainly from 2009 there hasn't been hepatology input other than as described when escalated for your patients with hepatitis C or hepatitis.
I think that's a very difficult question because I knew I was going to be asked that question. It comes down to individual cases, and the question of whether individual cases could have been managed better had they been more proactively being followed up in hepatology is a very difficult question to answer. We certainly, I think, picked up a number of severe liver-related complications quite quickly because we were doing regular ultrasounds of the liver and regular blood tests to detect liver tumours. Whether they would have been picked up more quickly had they been in a formal hepatology clinic, it is possible, but I don't know. That's a very difficult question to answer.
And so currently, patients with hepatitis are being managed through joint clinics with you and Dr. Shrivastava. And there's also the blood-borne virus clinic also has a role. What role does that clinic take?
Yes, so Dr. Shrivastava in the joint clinic the role there is to monitor people with regard to progression of liver disease and undertake surveillance. So, for example, some people will be on a surveillance program of regular ultrasounds, regular blood tests. Some people require regular endoscopy to look for esophageal varices. So that would be the role of the clinic with Dr. Shrivastava. In Wales, when the funding for the new hepatitis C treatments came in, these are the non-interferon based treatments, that funding was allocated so that people would be treated with the bloodborne virus clinic to offer treatment to eradicate the hepatitis C virus. So the hepatitis C eradication therapy is done through the bloodborne virus clinic, and that has all now been completed. So no one is attending the bloodborne virus clinic for hepatitis C eradication therapy because everyone who has elected to have treatment has had the virus eradicated. So there is, at the moment, no one attending that clinic. That clinic was run by Dr. Healy, and he was one of the, again, infectious disease microbiology experts, and he took the role on of managing hepatitis C eradication throughout the whole of the Cardiff area for all patients with hepatitis C.
Now I'm going to ask you some questions about medical records. Can I start by asking you this? The inquiry's heard evidence from a number of patients treated treated at Cardiff before you arrived by Professor Bloom, and they have told the inquiry that there were a number of key records missing from their medical records, gaps in their medical records, and so on. Is that something that you found yourself when you came to Cardiff and were treating patients? Was key information missing? Were key documents missing?
I think the only key documents that were missing, which came up in the audit by Dr. Hill, was that the people's HIV results were filed, they were all filed together, separate from the notes. As far as I'm aware, those are the only key documents that were not in the notes that one would have expected to be in the notes. When I arrived in Cardiff, all of the notes of the people who had died of HIV were in a cupboard in the office that I inherited, and we have kept those notes ever since. I am not aware that those notes have well, we've just kept them. I haven't been through them to look to see if there are key documents missing or elements that I think should have been there. I haven't been through the notes to make that assessment. So the only thing I'm aware of is this issue of filing HIV notes separately.
So when you come to treat patients, would you have to look through their notes to find key pieces of information? So if is that something you would have noticed? Would you have noticed that key documents are missing from the patients that you're treating from 96 onwards?
I think if there'd been any systematic issue, I would have noticed, yes. I can't remember a case where I've been unable to find the information that I was expecting to find. It was all, to me, clear what was there. So yes, I can't think of any issues.
You also say in your statement that that you've told us it's your policy to keep records of those who are infected with HIV after they've died. You've also said it's your policy to keep the records for the life of your patients. Do you know whether that's become formal hospital policy, or is that simply the policy of your centre?
It's the policy of the Haemophilia Centre to keep those. I think the policy in general in the NHS would be not to keep records of people who have died, for only for a period. And I think that if someone doesn't attend the hospital for maybe 10 years or so, the policy might be not to retain the records. Of course, someone with a bleeding disorder might not attend for 20 years and then come with a problem. And so we needed to retain the notes.
And the hospital tolerates your policy, do they, of keeping notes for the life of the patient and after their death?
Yes, there is no issue with that in the current situation. As you're aware, there was a time when there was I can't remember how long ago it was, but the inquiry has the documents where there had been this issue of trying to not store these documents for life, and I made the point that I thought we should, and I didn't get any pushback on that, apart from to say, well, you find the space then, which is what we've done.
Can I ask you now some questions about links with pharmaceutical companies? You've told us in your statement that 3 companies gave donations that helped build the new centre in 2000. Who managed that process with the pharmaceutical companies? Was that something that you were involved with?
Well, the money was paid into an endowment fund, so I wasn't directly involved in the transfer of the money. That we went through the finance department, but I was involved in sort of discussing with various companies whether they would be prepared to make a donation. The problem was that we had the agreement, because as I've said earlier, all the Haemophilia Centre had been disbanded and the people being treated on the Haematology Day Unit, having made an argument that we needed a new centre, a standalone Haemophilia Centre, and this was very strongly supported by the local patient group. We had a number of meetings with senior management, myself and the local patient group, to advocate for this. The agreement then was that okay, you can have a standalone Haemophilia Centre, but you're going to have to fund the cost of it, and that's why we were obliged to look for sources of funding. We had a number of different sources of funding that went to build the new centre.
And what sort of sums were the pharmaceutical companies contributing then to the building of the new centre?
It was round about 10 to 20,000 from my memory.
For each company?
Yes, that's from my memory.
And were they companies that you were companies whose products you were using at the time?
Yes, they were recombinant factor VIII product companies. So we approached all of the companies with the same request, and they either agreed or didn't agree.
What do you do, or what do you do at the centre, or you personally, to guard against any risk that companies contributing to the centre's work doesn't influence the decisions that you make about prescribing products?
Well, I think we've always been very independent about what products we would use. Of course, with the national tenders, we followed the national tender, so that then becomes much less of an issue, because we essentially have to fulfil the requirements of the tender, and I think that is a very big advantage of the tender, because it does remove the possibility or even perception that there may be influence on prescribing. So I don't think that process of donations to fund the building of the Haemophilia Centre had any influence on our decision to prescribe any specific brand of factor VIII.
And you've also described in your statement how pharmaceutical companies continue to fund clinicians attending educational meetings and activity patient days.
Correct.
Given what you said about the national contract, what do you think that pharmaceutical companies are getting out of that funding?
Well, clearly, from the point of view of the pharmaceutical company, they want to influence the prescription of their product. Whether that is the case or not, I don't know. I think that you will have discussed this with many of haemophilia doctors. I mean, I might be supported to go to a meeting by a different company each time. My colleagues might well be. So there is a sort of a balance there. As I say, I think that from my perspective, I don't feel that I've been influenced in prescribing policy, because the policy, as I've described, is sort of dictated by the national contract. That's my sort of understanding of the situation.
And can I? You mentioned in earlier on this morning that when you took over the centre, you inherited some files of papers from Professor Bloom. Have you come across correspondence between him and pharmaceutical companies in any of the documentation that was left at the centre and that you've inherited?
I haven't. I'm aware of some of the documentations that have been shown by the inquiry, but I haven't come across any documentation regarding an interaction between Professor Bloom and pharmaceutical companies. I didn't come across anything like that, no.
And knowing what you do about the way that documents are stored and the way that correspondence is generated, certainly in '96, where do you think that correspondence would have sat? Where do you think it would have been kept?
Well, I don't know. I would have thought that if there had been any correspondence, it would be in Professor Bloom's office, and I inherited his office when I went there. 3 people, as I said, had been consultant for the centre in between Professor Bloom dying and myself going there. So I didn't directly inherit his office, and so I don't. And as I say, I didn't come across this sort of documentation. Professor Bloom, of course, died suddenly, so his office would have been left sort of in the state that he was using it. There would have been no. It wasn't as if he retired and might have decided to get rid of documents. He died suddenly whilst still in post, so I can't explain. So, for example, I've not come across any even UKHCDO minutes from Arthur Bloom's time, so I just don't know where all those documents went.
So I've noticed it's 1 o'clock. I think I've got probably about 15 minutes more to go. So what I was going to suggest is that I continue for the next 15 minutes and then we take a break so that call participants can ask any questions that they wish to of me to put to.
Might it be more convenient, do you think, to come back at 2 o'clock and ask the 15 minutes then, having picked up the questions they may have to ask in the meantime?
I'm happy to proceed on that basis.
Well, let's... Oh, all right, let's go on for 15 minutes. Are you happy to go on for 15 minutes? Then take a break, or would you rather have a break now?
No, I'm happy to continue for another 15.
Right.
We've already looked at. I'm moving on to a new topic now, which is just a question on research. We've already looked at one of your studies. one of your articles rather. What I would like to ask you is the difference between, in your view, research studies and service evaluations. So the article we looked at previously was a service evaluation, and you've said in those circumstances you wouldn't get ethical approval, and you wouldn't seek patient consent, but you would if it was a research study. And I just wanted to explore with you where the bright line is, in a sense, particularly given that the example we looked at previously involved testing of stored sera, for example. So could you just explain to us where your bright line is between a research study and a service evaluation?
So my understanding is that if a person or a patient group are being treated by standard practice of the centre, and that routinely collected information is reported, then that is a service evaluation. A research study is asking a specific question. So you may say, we're going to change treatment and see what happens. That would be a research study and would require ethical approval and informed consent. I note that in the inquiry's ethics specialty group have specifically mentioned the difficulty of drawing the line between research and service evaluation, and I think it is a difficult situation that does need to be seriously considered. So let's say, for example, that we have a group of people. An example of this is that we wrote a paper about unclassified bleeding disorders. Over the years, we've looked after people with unclassified bleeding disorders. These are people who have bleeding during invasive procedures or at other times, but we can't find anything in the laboratory that explains that bleeding, so they're called unclassified bleeding disorders. And we've managed them according to standard practice, and so we have reported that as a service evaluation. That's the way we've reported it, and so we didn't apply for ethical approval, and we didn't seek informed consent. On the other hand, one of our team has done a PhD looking for the underlying cause of unclassified bleeding. So we submitted to the ethics committee. We invited people up, we explained the study, and we took written informed consent, and tests were done that aren't routine laboratory tests, but tests were done to see if we could find the underlying cause for the unclassified bleeding disorder. That's clearly research, and we did go to the ethics committee, we did get it passed by the HICS, and we did take written informed consent from the individuals concerned. So that's broadly where I'm seeing the line.
And
I could give another.
Sorry, yeah, carry on. Do carry on.
But I could give another example in my work in postpartum hemorrhage. So I've done about 10 or 12 years now work with colleagues in Cardiff, trying to improve the care of women who have bleeding after childbirth. And one of the main drivers for that is to try and reduce the amount of blood transfusion people require after childbirth. Now, we've done a number of studies where we have recruited women. We've been to ethics committees. The women recruited into the study give written informed consent, and they're research studies. But once we'd completed that research, we then applied the knowledge gained from the research to change the way postpartum hemorrhage was treated throughout Wales as part of a quality improvement programme. And that was a 2-year quality improvement programme based on the understanding that we'd gained from that research. Now, that involved essentially all the women giving birth in Wales, because all obstetric units in Wales took on this quality improvement programme. We've collected information from that quality improvement programme and demonstrated a very substantial improvement in the quality of care, a reduction in the number of women with severe bleeding, a very major reduction in the number of women receiving a red cell transfusion. However, that's a quality improvement programme. In order to report that, that isn't going to go to an ethics committee. We haven't taken written informed consent from the 60,000 women involved. We are reporting that as an evaluation of the service across Wales. So those are kind of the broadly where I see the difference. But I do agree that it is often difficult to know where to draw the line between these things. And on the paper on 8Y that you showed me earlier, I think we drew the line in the wrong place. Looking at that back now, I think we drew the line in the wrong place.
And it is the fact that the information is going to be, albeit the information about the patients is going to be anonymised, but the fact that it's going to be published, it's going to be able to be accessed by many people and analysed and so on. Is that relevant to the question about whether or not one gets consent, even if not relevant to whether or not one goes to an ethical committee?
I don't think. I think if you don't have to seek ethical approval, then I think it is reasonable to publish the aggregate data from a haemophilia centre. And as I've said, we've published in the aggregate data for all the births in Wales over a 2-year period. If we weren't able to do that, then all of that knowledge, which could substantially improve the quality of care, would be lost, because it's impossible to go and seek consent from 60,000 people. So I think there has to be some proportionality. I think that's the word that is used by ethics committees, and the Health Research Authority, the NHS Health Research Authority, does have guidelines on where you try and draw the line, but it sometimes isn't completely clear.
It is perhaps part of the problem, the word evaluation. It's I can understand the difference between reporting what is happening, on the one hand, making research into why it is happening, which is a separate issue, and making recommendations as to what should be done, which is a question of judgment or policy or proposal. Well, all three they're quite distinct in you can see them as being quite distinct, but they'll shade into each other. But the word evaluation suggests that somebody at some stage is making a judgment about something, rather than simply reporting what is, organising the data to show what is. Is there any truth in that observation or not?
I don't know. It's not my word. It's the wording of the NHS Health Research Authority. They have the specific section called service evaluation, and in that it is as I've tried to describe, that it's observation of routine care and routine collected information then being reported in an anonymised aggregate way. That's and they use the term service evaluation for that. It may be that a better term might be helpful, but that is the currently used term.
I wanted to ask you some questions about the National Haemophilia Database Research Registry, which you talk about in the UKHCDO section of your witness statement, i.e. with your UKHCDO hat on. Can you just tell us what sort of information is held within that research registry?
Yes, so the information held there is it's named the name of the patient. It's not anonymised. The name of the patient, the NHS number, the date of birth, information on their diagnosis, their factor levels, or the subtype of von Willebrand's disease. Information is held about HIV status, hepatitis C status. There's a large section about variant CJD, about people who were designated in the at-risk group for variant CJD and whether or not they've received an implicated batch in that context. That's all held there. There's a whole section which is called HemeTrack, which is patient-reported information. So an individual will, on their phone, they'll have an app. Every time they give themselves factor 8 or factor 9, they'll enter the information into their app, and that is uploaded to the National Haemophilia database. And then the Haemophilia Centre can see their own patient's data. So if a person in West Wales enters that they've had a severe bleed in the knee, we in Cardiff, we could be alerted to that. So we might then phone up and say, are you okay? What can we help? That sort of thing. And they're very useful in clinic because we can then go back 6 months and we can see the pattern of bleeds over the last 6 months. And if an individual has forgotten bleeds, we might say back in June you had this knee bleed, what was that about? And then they are reminded. And so that's very useful, and that's patient reported information, and it can then show whether, if after an individual, say for example an individual's on factor 8 prophylaxis and then they can't convert to emicizumab, does that mean that their bleed rate goes down? Do they get improved outcomes? And so very, very useful clinically. The other information that's collected is about people's joint scores. And so this is one of the most important markers of how well people are being looked after, because if their joints deteriorate over time, it suggests something is not quite right. If the joints are staying perfect over time, it suggests that good quality haemophilia care is ongoing. So that information, and it's all collated within the National Haemophilia database. And as you know from Professor Hayes' discussion, this goes back to, I think, 1969, and has evolved progressively over the years, with different types of information either being collected or not collected.
So when you talk in your statement, about the research registry, that is actually the database itself. It's not a separate part of the database.
It's technically is separate, because the database is the database, the National Haemophilia database, and that has a number of functions. It has the function of direct patient care, for example, through this HemeTrack mechanism, and for the issuing of patient bleeding disorder cards. So that's important, and it has a role for sort of service planning. So the Department of Health might want to know what the trend is in factor 8 usage over time, and we can give that information. Now, the research registry was set up so that the individual's data that was held in the database for those purposes could then, on top of that, be used for research purposes. And until that time, then people were informed that their information was going to the database and could be used for research purposes, but they hadn't given express consent. So the idea of starting the research registry was so that we would then go to each individual and give them the opportunity to say, the information held on the National Haemophilia database, I'm either happy or not happy for it to be used for research purposes. And that process, we put that to an ethics committee, because the database was then submitted to an ethics committee to consider that. Patient information sheets were produced and passed by the ethics committee, and the consent process was passed by the ethics committee. And then we started on this process of individually seeking consent in each haemophilia centre in the UK to do that. And that's the process that had been going on for, 2 to 3 years. That process had been going on. Professor Hay then explained in his evidence that was then superseded by the NHS Health Research Authority Confidentially Advisory Group, who then came back after we'd gone to all of this And many of us were very keen on continuing with this process because we thought it was a good thing to do. He was then informed that we should stop doing that and that we would apply for a Section 251. And so we have throughout this process, I think, and I think Professor Hay described this quite well, is that getting advice is one thing, but getting consistent advice is difficult. Even from the authorities that are supposed to be advising us, you get different advice and it changes with time. And it does make it very difficult for us to, with authority, know where we should be going. But that's the kind of the brief outline of the National Haemophilia Database Research Registry.
So anyone reading your witness statement, which was drafted, I believe, in September, needs to bear in mind that there's been an update about the consent process, which was given in evidence by Professor Hay when he gave evidence to the inquiry.
Absolutely, that the process has changed, and it's because the advice changed, and it does make it difficult to do the right thing when advice is changing.
And so is the position now that third parties may be able to access patient, not unanonymised, if I can put it that way, so patient data and the detailed patient information that you've described without the patients being asked for their consent?
Yes, so no one can access the data apart from UKHCDO. So only UKHCDO can access the data. And we have a data management working party that controls access to that data, and that has on it patient representatives, representative of the Haemophilia Nurses Association, the Physiotherapists Association, and representatives of the commissioners, and they have the overview of what can be done. We also have a group called the Data Analysis Group, which meets every month, which if a proposal for information comes to the National Haemophilia Database, so for example, if that's proposal from NHS England, for example, we would discuss that at the Data Analysis Group, and again that includes representatives of the patients, it includes representatives of the haemophilia nurses and physiotherapists, and we decide whether that information is reasonable to give. And so that is the situation. So the situation now is that a proportion of people have given express consent for their data to be used for research. And in Cardiff, we got quite a lot of people had written and done their informed consent, well in the hundreds, but now there's a group that hasn't because we've been told to stop the process. So it is, in my view, a bit unsatisfactory, the advice that we've received from the confidentially advisory group on how this is going.
So sorry, and forgive me if this is my fault, but is the research that can be done simply by the UKHCDO? It's not by pharmaceutical companies. They wouldn't have access to that information if they made an application.
Would not have access. No one has access apart from UKHCDO.
So all the research would be within the UKHCDO. It
would be, and the people who do the analyses, the statisticians, they don't see. They see anonymised data, so they don't see anything like the patient's name or date of birth or anything. They see anonymised data, and they will then do the analyses. And they do essentially. It shows aggregate data. So, people receiving treatment X would have this number of bleeds per year on average. That's the sort of information that is available.
And then just lastly, before I've gone slightly over my 15-minute time estimate, but can I just ask you two more questions? First one is out of what you wrote at paragraph 320 of your witness statement, and it's this. The transmission of HIV and hepatitis to patients with bleeding disorders has dominated my consultant practice in the way I approach the management of people with bleeding disorders. I just wanted to ask you to expand on that, if you can, the ways in which the infection of patients with bleeding disorders has dominated your practice.
Well, I think this is all through my career, both in training and as a consultant. It has always been a major aspect of looking after people with bleeding disorders is the management of the complications of the infectious diseases that were transmitted. When I first arrived in Cardiff, people were still dying of AIDS because the highly effective treatment was only really sort of came in early in 1997. So people were still dying of AIDS, and we had to look after people in that very difficult situation. Since 1997, in Cardiff, we haven't had anyone die of AIDS. Obviously, people with AIDS have died potentially of complications related to that, but not died specifically of AIDS because the treatment has improved. But that still dominates your thinking when you are seeing patients that clearly the treatment that has been given by the centre has caused major problems for an individual is always very high in your mind when you're talking to people. And it's the same with hepatitis C. If you always know and you always understand that. I think then the variant CJD issue did come to in many ways really dominate things in the early 2000s, as we had to then go to people and say that you are going to be put into what's called the at-risk group for variant CJD for public health purposes, and then explain what that meant, because that's not an easy conversation to have. And again, that became a dominant feature of our practice at that time, because the uncertainty was very difficult for people to deal with, because they know the history. They are then being told that maybe that this might be another problem, but again, we don't really know. That's very difficult for people to have to listen to and understand. The other way that this is really continues to dominate, is, as I explained earlier, many of the mothers who look after and have children with haemophilia nowadays, they've lost members of the family to HIV or hepatitis C, and it's always with them. And when you're seeing those families, you know it's always with them, and you have to discuss things in the context of understanding how they might feel about having a child with haemophilia, knowing the problem that it's caused their family member. It does, and I think it's both for myself and for all the people who work in Cardiff, it does dominate our thinking in terms of how we try to approach things, because clearly we can't put anything right, but I think acknowledging what has gone wrong is very important.
And lastly from me, before we break, the inquiry understands that the statue of Professor Bloom has been removed from the centre and that the centre is no longer named after him. Can you tell us how that decision came to be made and why?
We were contacted by Haemophilia Wales, and there was, from what I understand, Haemophilia Wales did not want the bust of Arthur Bloom to be removed and the centre renamed. They wanted to wait for the outcome of the inquiry, and for the inquiry to give their views, and once that was known, Haemophilia Wales wanted to then make a decision on whether to change the name of the Haemophilia Centre and remove the bust. And I discussed this with Haemophilia Wales on multiple occasions, and that was their consistent view. They wanted to wait for all the evidence to be presented before a decision was made. However, they got to a position where they were experiencing pressure to remove the bust, and they approached me and said that rather than the Haemophilia Centre becoming the centre of the story, they wanted us to remove the bust and wait for the inquiry to give its opinion. So that's my understanding of what happened. Clearly, Haemophilia Wales can give their understanding on their version of that, but that's the way I felt it happened. The day that Haemophilia Wales said that they wanted us to take the bust down, we took it down, and that wasn't the unanimous decision of Haemophilia Wales, but it was as I understand it, the consensus decision.
Thank you.
Well, let's take a break then, shall we, till would 2:25 be all right for you, Professor Collins?
Sorry, what was the time again?
Would 2:25 be all right for you?
Yeah, that will be very good, thank you.
So 2:25 then.
Okay, thank you.